That seems to be all right. So you can see my slides. It's full screen.
Yep.
Yeah, I can see those.
Yeah, that looks great.
Trying to...
So if you both are happy, I'll just start adding the people in now.
Yep.
Emily, you're good to take it from there.
Okay, so good evening, everyone. Welcome to NANSIG Journal Club. I'm Emily. I'm the neurosurgery research lead, and in just a moment, I'll introduce you to two incredible neurosurgeons. So tonight, our focus is a landmark study recently published in The Lancet, ULTRA, or in long, ultra early tranexamic acid in subarachnoid haemorrhage. So we're honoured today to have Dr. Rene Post. He's a PhD candidate at Amsterdam University Medical Centre, joined by Professor William Vandertop, who's the chair of neurosurgery and has a world-renowned academic profile. So without further ado, I'll introduce you to Dr. Rene Post.
Yeah, thank you, Emily, for your kind introduction, and also, of course, for the invitation to speak here and present our results of the ULTRA trial that's recently published in The Lancet. As said, I'm Rene Post. I'm a neurosurgeon working at the Amsterdam University Medical Center in Amsterdam, and I performed this trial largely during my neurosurgical residency. I'm presenting these results on behalf of the entire ULTRA trial study group. Well, first, the disclosures. The ULTRA trial was funded by Fund Nuts Aura and the Department of Neurosurgery in the Amsterdam UMC. It was an investor-initiated trial, so we largely depend on the financials from the Fund Nuts Aura and Amsterdam UMC, and I have no personal disclosures myself. Well, first, let's start why we did this trial. Well, so maybe not all of you know, but a recurrent bleeding is a devastating complication of a subarachnoid hemorrhage, and it can occur up to 22% in the first 24 hours after subarachnoid hemorrhage, and it's associated with a poor clinical outcome. And the only two means to prevent the recurrent bleeding are the treatment of a causative aneurysm or by use of antifibrinolytic drugs. Well, antifibrinolytic drugs that inhibits the fibrinolysis of a blood clot that has been formed after a bleeding in an aneurysm, and it can reduce the risk of a recurrent bleeding up to 80%. There are several trials, even dated back to the 70s, that try to use this drug to reduce the number of rebleedings in subarachnoid hemorrhage in order to improve clinical outcome. The most recent Cochrane review that was published in 2003 and updated in 2003 showed, however, that by putting all of these trials, we found that there was no clinical benefit in outcome. And in this Cochrane review, there was only one trial, and it was published in 2002 in Sweden by Hillman et al. And that showed that if when giving antifibrinolytic drugs ultra early, that means within 24 hours, and not giving it too long, but for short term within 72 hours and then stopped, they found that it can reduce the number of rebleedings and they do not increase the number of ischemic events. This was the only trial that showed this, because the older trials that were much older were largely from the 1780s, and it was before the introduction of a calcium antagonist treatment like nimodipine that is nowadays mostly used in treatment of subarachnoid hemorrhage. And these older trials, they give antifibrinolytic drugs throughout the entire hospital admission. And by doing so, and by giving it long term, they showed much more ischemic events in the patients. So on the other hand, they did reduce the number of recurrent bleedings by giving long-term antifibrinolytic drugs. But on the other hand, they saw much more ischemic events in their trial populations. So we aimed to assess whether ultra-early and short-term treatment with tranexamic acid should benefit clinical outcomes after 6 months in patients with a subarachnoid hemorrhage. And ultra-early we defined as within 24 hours and short-term not longer than 24 hours. So it was much shorter than the trial that was published by Hillman et al. In 2002. Well, it was an investigator-initiated study, multi-center throughout the Netherlands. It was an open-label trial with blinded endpoint assessments, a so-called probe design. And we did not a placebo-controlled trial purely based on the financial costs. An open-label trial is much easier to do as an investigator. If you don't have the support of the pharmacy, then it's very difficult to do a placebo and very costly. It costs a lot to do it placebo controlled. So we did an open label trial and we powered on 950 patients in a one-to-one randomized block. And one group was the standard care and the other group was the use of tranexamic acid. And if the patients were allocated to the tranexamic acid group, they received 1,000 milligrams of tranexamic acid, and it had to be administered within 10 minutes, and it were followed by 1 gram immediately after that, and it was continued every 8 hours until a maximum of 24 hours. Then the tranexamic acid infusion was ultimately stopped. Or if an aneurysm was secured within this time period, we also stopped the treatment with tranexamic acid because it was no longer necessary because the risk of a reboot was obliterated by occluding the aneurysm. So I said we started in 2013 in end of July, and it took like 6 years, the whole part of my residency to finish the study, and well, the last follow-up was assessed end of July in 2019. So ultimately, we performed the study multi-center throughout the Netherlands. 8 subarachnoid treatment centers participated, and 16 referral centers also participated in the trials. You can see here in the picture the figure that the black dots and the red dots are the treatment centers, and the referral center are listed with the pink dots. So patients could be included in the trial if they were 18 years and older, and they must have a CT confirmed subarachnoid hemorrhage that was diagnosed on a non-contrast CT. So because we want to make the study so pragmatic as possible, and not every referral center in the Netherlands is equipped with a high definition CT angiography, we included patients only based on a non-contrast CT scanner. And the last onset of symptoms between ictus and admissions had to be within 24 hours. Because we were giving tranexamic acid, there were some exclusion criteria, like if a patient had a severe renal failure, then they could not be included in the trial. If patients were pregnant, they could not be included in the trial. If patients had a history of a hypercoagulation disease, such as factor V Leiden, they were excluded from the trial. If they have a current treatment for deep venous thrombosis or pulmonary embolism, that was defined as not as early as only at most 6 months since diagnosis started, they could not participate in this trial. And if patients were expected to be moribund, that will suppose an imminent death was suspected within 24 hours. We did not include these patients. Also, because we had only a CT, non-confident CT, and not a CT angiography in most of the patients, we include this pattern of subarachnoid distribution as an exclusion criteria. Perimesencephalic bleeding pattern was one of the exclusion criteria, combined with no loss of consciousness. So the patients with acute headache with no loss of consciousness, but had a strictly perimesencephalic pattern, we did not include in this trial. And also, if the bleeding pattern was consistent of a trauma, patients were also excluded from this trial. Well, the primary outcome was the modified Rankin Scale. We assessed it at 6 months. That was an interview. Patients had a telephone contact with a research nurse, and they used a structured interview to score the modified Rankin Scale. And it's a score that determines outcome, and it ranged from 0 with no symptoms until 6, that's death. And it was the primary outcome of the trial. We assessed the complications that were happening during the trial, like recurrent bleeding or hydrocephalus, or a delayed cerebral ischemia and other ischemic events during this trial and during admission. And a quality of life and a healthcare cost questionnaire was assessed at 3 and 6 months. Currently, we are analyzing the results of these questionnaires and will be published in another paper and lie out of the scope of this talk. But the unique thing of the trial was we used the deferred consent procedure. That means we included patients without prior informed consent, and we can. It was the local board has approved this because we want no delay in the start of treatment of tranexamic acid, and we believed it was the most ethical way to include patients by deferred consent. Of course, if patients were included, consent was obtained as early as possible. Several centers thought there will be a lot of refusal of consent from patients because of this consent, but only less than 5% of all patients that were initially randomized in this trial refused informed consent. So it was much lower than we initially thought. Well, ultimately, we randomized 955 patients that were assigned to either tranexamic acid group or a control group. And in both arms, 5 patients were lost to follow-up. There was a high adherence to the protocol, and from the 480 patients that were allocated to tranexamic acid group, only 20 patients did not receive tranexamic acid treatment. And in the control group, there were only 2 patients that did receive tranexamic acid. 1 patient demanded that he was treated with tranexamic acid, and 1 treatment was already given in the ambulance because the cross trial of course give sometimes tranexamic acid in the ambulance, and this patient was supposed to have a trauma and already was given 1 gram of tranexamic, so was well included, but ultimately so in the control group this patient did receive tranexamic acid. So we look at the baseline of the study. In both groups, the characteristics were evenly distributed between these groups. So you can see here in the figure, the time between the moment of the subarachnoid hemorrhage, the ictus, to the first CT scan was in a medium in half of the patients 93 minutes. So it's quite fast. Yet the Netherlands is a small country, so patients are presented in the hospital very fast. And the time after CT diagnosis of the subarachnoid hemorrhage until aneurysm treatment was in half of the patients 14 hours, and 75% of the patients were treated within 20 hours in our study. In about 15% of the patients, there we found no causes of aneurysm. It was because the design was very pragmatic built, and the diagnosis was made only by non-contrast CT. There were some like 15 patients that did not have an aneurysm eventually. Well, the primary outcome. We did not find a difference between the use of tranexamic acids and control between study groups. 60% of patients had a good clinical outcome in the tranexamic acid group versus 64% in the control group, not statistically significant. And by correcting for treatment center, it remained not significant. Well, beforehand we defined some secondary sensitivity endpoints to see how robust the results were from the trial. So a secondary outcome point was excellent clinical outcome, and we defined the outcome, the modified Rankin Scale, a little bit more strictly. The score 0 to 2 is mostly used in stroke trials, all the stroke trials, with ischemic stroke trials. Not so much in subarachnoid hemorrhage. Then the most used score is a modified Rankin Scale between 0 and 3. But if we were more strictly, then we saw that by giving tranexamic acid, there was a negative effect on excellent clinical outcome. 48% of the patients had an excellent clinical outcome versus 56% in the control group, and that was indeed statistically significant. However, when we did a sliding dichotomy, as can be seen in figure 2 here, and the groups were split between each group, and the percentages are given here for the MRS 0, 1, 2, 3, and up to 6. And we did not find that it remained significant, not by doing without adjustment or without adjusting for treatment center. Furthermore, we did not find a difference in the 30-day mortality after admission, and also not at 6 months. There was no difference in the mortality rates between these two treatment groups. So, where we're looking at safety, we found slightly lower proportions in the number of recurrent bleedings in our trial. We're looking at all suspected rebleedings before aneurysm treatment and after randomization. We found that in 10% in the tranexamic acid group had a recurrent bleeding versus 14% in the control group. However, this was not statistically significant. And when we're looking only at CT proven recurrent bleedings, we found percentages of 9% in the tranexamic acid group versus 12% in the control group, also not statistically different. If you look at the other safety outcomes regarding thromboembolic complications during treatment or seizures, urinary tract infection, pneumonia, or meningitis, we did not find any significant differences between the treatment groups. What's interesting to see is that not only is a devastating disease, a subarachnoid hemorrhage, but the patients are really vulnerable. But because if you look here on the top of this table, we see that in both treatment groups, almost 80% of the patients that were included in the study had at least one serious adverse event. So there's much to do here for the future to try to decrease this number of events that occur during the hospital admission. So to conclude, the primary outcome defined as modified Rankin score 0 until 3 was not different between the treatment groups. We did saw a reduced rate in the number of rebleedings in the tranexamic acid groups. However, it was not significant. One explanation is that patients were treated very early. Within 24 hours, more than 75% were treated for the aneurysm. And we also know from future papers that the first 3 hours are the most crucial, because 50% of all recurrent bleedings happen within the first 3 hours. And we stated in the appendix in the article that the median time between the moment from the signs and symptoms regarding subarachnoid hemorrhage and the first start of tranexamic acid was around 180 minutes. So possibly we missed a lot of recurrent bleedings before we can either randomize these patients. And if we were more strictly in our outcomes and actual clinical outcomes, we saw that it was worse in the tranexamic acid group. A possible explanation could be that in this group there was more early brain injury, or it can be that there were more complications in this group that were not previously defined. But it's interesting to see, because it's not quite what we expected to see, that giving tranexamic acid can lead to worse outcomes in this kind of patients. So based on this trial and previous evidence, we do not support routine use of tranexamic acid in spontaneous subarachnoid hemorrhage, and we cannot recommend it based on the results of this trial. So that's what I wanted to tell you about the study and the results we found, and maybe there's some questions.
Excellent. Thank you very much for that talk. I think it's really inspiring to see such high quality research for budding neurosurgeons like myself, and I'm sure the people watching this talk. So we'll open up the discussion now. I think there's already a couple of questions in the chat. So George has asked, have you any theories about why tranexamic acid doesn't improve patient outcomes? I know there's work going on at the moment looking at and the role of inflammation. So do you think this could be a bigger factor in patient outcomes?
Well, we of course, when we started this trial, we believed that we can reduce the number of recurrent bleedings with tranexamic acid. But interestingly, we were not able to do so. And we were probably too late by giving tranexamic acid. And on the other hand, treatment, the sense of urgency to treat the aneurysm has been much higher than previous studies. So the window of opportunity to reduce the number of rebleeds is possibly too narrow. Because we're treating these patients now so much faster than we did in the earlier days. I see that my colleague has hold his hand up, so he probably wants to elaborate a little bit more.
Okay, we'll just unmute. Yes, I think you've unmuted Professor Vandertop.
Unmuted myself, yes, thanks. I think it's very important to realize that tranexamic acid is a wonderful drug in reducing rebleeds, and that's why it's been given since the 70s and the 80s. And the big problem is that no one could prove, or everyone actually proved, that it was a wonderful drug to reduce the rebleeds, but no one could show that it actually benefited the patient. And that was largely a power question, having enough patients in the trial. And that's why it took us 6 years under national effort to have such a large population that finally we had enough statistical power to show that at 6 months, it actually didn't help the patient at all. And also, to our surprise, that it didn't reduce the rebleeds as it had in the past. And the explanation that we had for that was that aneurysm treatment has changed tremendously in the past decades from the guidelines in America and in Europe say that you have to treat within 72 hours. And as you see in our trial, we treat them a mean of 14 hours. So most rebleeds in the past don't occur anymore. And if your natural rebleed rate is already lower, then tranexamic acid won't be able to further reduce that. And there was one question that wasn't answered about the 6 months, whether the differences would be expected over a longer time. There's been a lot of research in subarachnoid hemorrhage that 6 months is actually quite a good time period to see that the patient has more or less stabilized, and that it has no benefit in checking them for longer, for 12 months or whatever.
Thank you for answering those questions. Has anyone else got a question? So what was the reason for excluding patients with a good grade perimesencephalic subarachnoid hemorrhage?
Well, because we did a pragmatic study, and we only included, in some referral centers in the Netherlands, they don't have a high definition CT angiography. So a large of the patients that were seen there did only have a non-contrast CT. So that was the reason. The patients that had a good clinical scale with no loss of consciousness, with a perimesencephalic pattern, are more likely to not have an aneurysm lying as a cause of this bleeding. And because not all centers in the Netherlands have a high definition CT angiography, we use this as an exclusion criteria. But when we did the power calculation, we know we would include a proportion of patients that will not have an aneurysm. So we adjusted the number of patients according so.
But the main reason is, of course, that perimesencephalic patients have a wonderful outcome in the long run. They don't develop complications. They don't develop rebleeds. So that's the reason to exclude them. So if a radiologist in a non-academic center was comfortable in saying this is a perimesencephalic pattern, then he was excluded. But because we knew we would get patients who had been included into the treatment center, and that our neuroradiologist with experience would say, oh, this isn't aneurysmatic pattern, but this is a really perimesencephalic pattern, we would have to eliminate them from or we didn't really eliminate them, but it wasn't really the target population. So as Dr. Post mentioned, we made sure in the power calculation that we included to correct for that. And a 10 to 15% not aneurysm that someone asked is quite a normal percentage. Of all patients with a subarachnoid hemorrhage, you expect to find 10 to 15% without an aneurysm. And a few percent of those patients are perimesencephalic, and about 5%, and 10% of those patients have what we call an angiogram negative subarachnoid hemorrhage. So perhaps they did have an aneurysm, but it exploded and the vessel wall repaired itself, and then you don't find it on repeat angiography.
Thank you for answering that. Does anyone else have a question at all? If you could pop it in the chat. So someone's asked if the mechanism of the trauma preceding the subarachnoid hemorrhage played a role in how you interpreted the results.
I'm not sure. Can you repeat the question? I'm sorry.
So it's just on the chat here.
Yeah, what they say is the mechanism of the trauma, but we excluded the traumatic subarachnoid hemorrhages. So if someone had a car accident or fell off a ladder and he had a subarachnoid hemorrhage, then he was excluded. If you say that rupture of an aneurysm is the trauma, then the question is not quite clear to us, because the mechanism of rupture, we don't know. It's hypertension, it's weak vessel wall, exertion.
Okay, thank you. And do you have any future research planned that's been sort of spurred by this study?
Well, the first question asked was about the inflammation part. And that's very interesting, because we used to think that the patients with subarachnoid hemorrhage, they develop a tremendous number of complications. And one of the complications is delayed cerebral ischemia. And we always thought that that was vessel narrowing of the proximal arteries, so vasospasm. And the last 10, 20 years, it's becoming clear that it's far more a problem downstream, more in the capillary network and in the arterioles, and that perhaps indeed it's inflammation of vessel wall. And what we're in the process of doing is organizing another trial in which we want to treat, well, not exactly the inflammation, not with the medication, with the drug that was mentioned, that anti-rheumatic drug, but what we really want to do is we want to give naproparin, that low-weight molecular heparin, and then not in a prophylactic dose, but in a high dose. Because another paper by Dr. Post published in Neurosurgery, that was our retrospective series, we saw that those patients who had a therapeutic dose of low molecular weight heparins fared much better than the patients who only received a prophylactic dose. So we want to do that in a prospective randomized trial. And for the coming months and 2 or 3 years, we'll be very busy answering sub-questions from the ULTRA trial, because there's a lot of data still to be analyzed.
Excellent, thank you. And Mark's asked, was there a difference in outcome between aneurysms that were coiled or clipped?
Well, we're looking at those subgroups at the moment, so this data is not ready yet.
Can't answer that question yet.
Okay, thank you. Okay, well, I don't think we've got any more questions for now. So thank you ever so much for talking to us today. It's been a really valuable experience for me, and I'm sure all the others on the talk. So thank you very much.
You're very welcome.
Welcome.
Our pleasure.
Thank you.
Emily, okay to share the feedback, post that, is that all right?
Yeah, I'll just post the feedback form for anyone attending to fill out.
Okay, thank you. Bye-bye.
Thank you. Bye. All the best.
Guys, really appreciate it.
Bye-bye.
Bye-bye.
Thank you.